Hey, everybody. Welcome to another episode of Ortho Carolina's monthly live webinar series. My name is Bill Cregar, and I will be talking about common pickleball injuries. This is being live streamed on all our social media platforms, so please do not hesitate to ask any questions in the comments, and I will try to address them at the end of the presentation. So just wanted to introduce myself. My name is Bill Cregar. I am one of the orthopedic sports medicine surgeons here at Ortho Carolina, mainly based out of our downtown locations at the Sports Medicine Center and South Park offices. As you could see here, my specialty is mostly sports centered with a majority of shoulder, elbow, and knee injuries. Professionally, a little background about me. I did my undergraduate training at the University of Georgia. I was a swimmer there and enjoyed my time in Athens. Go Dogs. After that, I moved up to Richmond, Virginia, where I went to medical school at VCU. That took me to residency out in Chicago, back to fellowship here at Ortho Carolina, and I was in practice for a couple of years in Indianapolis with Ortho Indy before returning back home to the Charlotte area where I am now. On the non-professional side, my main hobbies are taking care of my kids. I've got 3 young boys, 1, 3, and 5, so my wife and I are very, very, very busy at home. I wanted to start off with the goals of this talk. Obviously, we're talking about common pickleball injuries, so my 3 main goals are to discuss the common pickleball injuries, risk factors, how they typically present, and the common treatments that we have for them. The second big thing is how to triage these injuries from your perspective. So is this a situation that you can self-manage on your own, or when is it time to see a doctor? And lastly, most importantly, our prevention strategies. So how can we prevent these injuries from occurring in the first place? So pickleball is the fastest growing sport in the U.S. over the past 5 years. Even in 2023, there were reported 36.5 million participants, and that number has probably doubled 2 years later in 2025. One of the biggest reasons it's exploding is because it's adaptable across all activity levels. It's a smaller court size than a tennis court, less running, and generally lower impact when you compare it to other racket sports. A third of players are over 55 years old. It's one of the only sports that we see that. And there's a lot of benefits that come with it. Fitness, the concept of being able to master a difficult technique, the socialization component to it. And for all the former athletes, the competition is good to be a part of. And there's even some studies to suggest that lower levels of depression amongst adults that play pickleball. So with this surge in participation, we see a surge of injuries, not surprising. At least 2/3 of players will actually sustain an injury annually while playing pickleball, and they commonly involve the knee, shoulder, elbow, and ankle, as well as the back. I'm going to focus mainly on the knee, shoulder, elbow, and ankle in today's talk. What are the predictors of injury? Well, the typical person is a male between the ages of 33 and 77. The higher frequency of play. So what we see is if you're playing more than 3 times a week, that tends to put you in a higher risk category. Fewer years of experience, less than 5 years of play, and then which commonly makes sense is a lower perception of prevention typically puts you at risk. When we look at the injuries by breakdown of category, a very, very large majority of injuries are soft tissue related. Second, followed behind that is a tie between fractures and arthritic flare-ups. When we break down these injuries by age group, we could see if you're under 40 years old or younger patients, we could see soft tissue injuries predominate. And then if you're older or above 80, that's when we start to see fractures creep up. And this is likely due to balance strength issues that predispose you to falling, as well as a combination of weaker bone health in general. So here are the common pickleball injuries that I'm going to talk about. From a shoulder perspective, we're going to talk about the rotator cuff, which everyone knows about and cares about. The knee, we'll talk about sprains, strains, and arthritic flare-ups. From an ankle perspective, an ankle sprain is one of the most common injuries. We'll also talk about Achilles tendon ruptures. And then from an elbow perspective, we'll talk about the tennis elbow, or what we'll phrase as the pickleball elbow. Starting out with shoulder. So the rotator cuff. A little bit of anatomy. It's a group of 4 muscles that basically drive shoulder movement and shoulder function. When we talk about the most common pickleball injury from a shoulder, we're typically talking about a rotator cuff strain, tendonitis, or bursitis, which all kind of mean the same thing, or impingement syndrome. Rotator cuff strain is typically an overuse injury where we have a lot of repetitive overhead swings or racket swings or movements of the shoulder, and we can get kind of 2 conditions. As you'll see on the right, we can either get a tendonitis, which is inflammation of the tendon proper, or inflammation of a fluid sac above the tendon called the bursa, and we commonly name that bursitis. How does this typically present? Well, it's lateral shoulder pain and soreness. Typically, that pain is worse with overhead activities, and there can be some level of weakness associated with it. How do we typically treat this? Well, rest and cessation of overhead activities allow the body to its ability to heal itself. Sometimes we will add oral anti-inflammatories or even a corticosteroid injection into the subacromial space in that bursa with persistent inflammation. And then therapy exercises, which are one of our most important forms of treatment where we're trying to get the rotator cuff to reactivate and strengthen the rotator cuff. This is a very, very important slide because a lot of what we see in the shoulder world, especially with tendonitis and bursitis and impingement syndrome, comes from an issue that we can easily prevent. And I want to kind of clue you into this slide because I think it's important. I won't try and get too technical because we can get into the weeds, but our shoulder health is kind of driven by our posture and muscle balances. Muscle balances meaning the chest and the back muscles. What we typically see with a lot of people are poor posture and kind of this rolled position, as you can see in this patient right here. That's called scapular protraction. What that does is it essentially limits your ability of range of motion in the overhead position. You can see this side profile. You can't necessarily get your arm up overhead as high if the scapula is protracted. What that does is that puts you into an impingement position, and it predisposes you to developing rotator cuff issues. So a lot of things that we see in the shoulder, like tendonitis, is due to poor posture and can be easily corrected if we can increase or improve our posture and resolve the muscle imbalance issues around the scapula to be similar to how this demonstration is here, where you could see the scapula is retracted and we have more motion above head, less risk of impingement and inflammation to the rotator cuff. So a lot of our prevention strategies that I list here are improving your posture, increasing the posterior chain or the scapular stabilizers to allow the scapula to open up and give us a pain-free and impingement-free range of motion above with our overhead sports. Obviously, maintaining shoulder flexibility is important, and building the endurance of the rotator cuff. It's similar to, the analogy I give patients in clinic is if you're going to run a marathon, you're not going to get up to the couch and run a marathon on Sunday. You're going to build the endurance and the running mileage similar to playing pickleball and overhead sports. You're going to build the time you're swinging the racket slowly so that the body adjusts and gets used to the endurance of the racket swings. And then, of course, appropriate warm up to activate all the muscles is always important in preventing rotator cuff issues. Here is a great resource. You can go online and type this in, but AAOS, or our governing body of sports med, has a rotator cuff and shoulder conditioning program that you can easily access online that basically walks you through a lot of rotator cuff and scapular strengthening programs that you can partake in and use to prevent shoulder injuries. This is probably one of the most common issues we deal with acute injury of the shoulder. Is it tendonitis or is it a tear? Felt like I could put in an easy chart, and this is a general rule, so it's not hard evidence, but in general, how do we tell the difference between tendonitis and a formal rotator cuff tear? Well, if we look at the frequency, by and large, a strained tendonitis or bursitis is much, much more common than acute rotator cuff tear. The mechanisms are a little different. You're talking about an overuse type mechanism for the rotator cuff strain, as opposed to a big injury or an isolated fall with the rotator cuff tear. Symptoms can be very similar, but there are differences. One of the biggest differences is the rotator cuff tear is acute onset. Usually it's associated with an inability to lift the arm and significant weakness, and you can even get bruising and swelling to the lateral aspect of the arm. The rotator cuff strain is usually more of a progressive pain. You can still play your activities and use the arm, but it's worse after those activities, and you really have a component of this achiness or soreness in the shoulder at night when trying to sleep. Both present with lateral shoulder pain. Usually the strain is improved with rest and the rotator cuff tear is not. Treatment-wise, we went over the treatment for rotator cuff tendonitis already. And it's typically surgery for the acute rotator cuff tear, not always, but in general, and that's usually a patient-surgeon discussion. And then lastly, when to see the doctor? Well, if you fail to improve with initial self-treatment in the rotator cuff strain tendonitis, but if there is any suggestions of you having an acute rotator cuff tear, it's usually good to see the doctor right away to determine that and undergo a further workup. All right, on to the knee. So sprains, strains, and flare-ups. So what is a sprain? Well, a sprain actually is an injury to a ligament in the knee. So the ACL or the MCL, for example. This is different than a strain. A strain usually means that we're irritating the lining of the knee or one of the muscles or tendons that surround the knee. And then lastly, an arthritic flare-up is usually an increase or an acute onset pain, swelling, and inflammation in a joint that is arthritic already. What are the causes? Well, twist, fall, or misstep that we commonly have in pickleball injuries when we're moving side to side. This is typically presents as an acute onset pain, swelling, and you can even get bruising in this area. And oftentimes you'll hear a pop, which can or cannot indicate an actual ligament tear. Usually with the sprain and strain, you're able to maintain the ability to weight bear, or at least for a period of time. If you're non-weight bearing, that improves with, a little bit of rest, going to the sideline and being able to walk on out. How do we manage these? Well, treatment is generally like everyone hears, rest, ice, compression, and elevation, all aimed at reducing the inflammation. Occasionally, we'll use oral anti-inflammatories to reduce the inflammation as well. And then occasionally, usually in the arthritic flare-up, are we considering a corticosteroid injection into the joint to reduce inflammation throughout the joint. I typically have patients go into a compressive knee sleeve to help with the swelling as well and stabilize the knee. I'm not a huge fan of formal knee braces that have any rigid support on the side. They can tend to hinder your recovery a little bit, prevent range of motion, and prevent reactivation of the muscles. So in general, I say a compressive knee sleeve is the most support that I like, as opposed to a rigid knee brace. And then lastly, relative rest and activity modification, giving the body a chance to recover from the acute injury and heal itself. What are the red flags? So how do we know it's more than just a sprain or strain? Well, if you have any of these, then typically it could mean that it's more than a strain. It could be a ligament tear. It could be a fracture. And these are really some of the indications, hey, maybe it's time to see a doctor. If there's severe pain that's worsening with time, if there was a sensation of any part of the knee dislocating, that would put you in a different category of a strain or a sprain. A persistent inability to bear weight is not normal, and you have persistent tenderness over the bone. That's when we start to worry about a fracture. If there's severe swelling or bruising, a significantly reduced range of motion of the knee, unable to fully extend it or flex the knee, and if there's persistent mechanical symptoms, so clicking, catching, or locking of the knee, those are all red flag symptoms and usually signs or symptoms that it's time to see a doctor to have a further evaluation. When we look at all three of these entities, we can kind of break them down: a knee sprain, strain, arthritic flare-up, and then how do we know it's not a meniscus tear, which is a commonly involved injury that we see in pickleball, but much more less common than a sprain or a strain. Here's kind of a cheat sheet chart of how to differentiate. Obviously, the meniscus tear is much less common than a sprain or strain. They all can be acute twisting type injuries, but typically the arthritic flare-up is an overuse. You do too much, you played too many hours of pickleball one day, and you're swollen the next day. They all present with pain. Usually a meniscus tear is more more swelling throughout the knee. So what we call a large effusion, where the knee looks like a balloon. The sprain or strain can have a little bit of swelling, but the predominant finding is just pain. Usually a sprain or strain or an arthritic flare-up will resolve with rest and improve with rest. A meniscus tear is an ongoing issue that can cause persistent symptoms. Treatment-wise, we talked about the sprain, strain, and arthritic flare-up. The meniscus tear is a little bit different, surgery versus non-operative. I won't get into that during this talk, but it's definitely a patient-surgeon discussion about how to manage those. And then lastly, when to see us. Well, if there's any concern for a fracture, a ligament tear, you're not responding to any self-treatment, you have a persistent inability to bear weight, those would all be worrisome signs. Like we talked about the red flags, it's time to see a doctor for your knee. So what are predisposing factors to knee injuries? Well, again, like the shoulder, muscle imbalances play a huge role in preventing knee injuries. Here's an easy test that I usually perform in clinic to see, okay, are there any glaring muscle imbalance issues? It's called a single leg step down. So you can get up on a step and slowly step down with all your weight on one side. And what we're evaluating for is balance issues. So usually the muscle imbalances that drive the knee are hip related, core and hip related. So you can see people that kind of tilt their hip on the single leg step down or can't maintain their balance at all. That's usually a sign of weak hip abductors. And by strengthening those, you can really reduce your risk of knee injury. Overweight patients that carry more weight, when they do have a twisting injury, there will be more force and you can have a higher rate of injury. And then deconditioning in general. So we see the injuries tend to happen in people that don't have the endurance buildup. When the endurance is not there, the muscles get fatigued easily and stop working, and they no longer protect the joint and predispose you to injuries. Our prevention strategies are aimed at the predisposing factors. So we want to resolve those muscle imbalances. Again, those big muscle groups are the core, the glutes, the hip abductors, and the VMO muscle that really drive knee health. Those are all aimed at improving single leg balance. We want to maintain appropriate weight, and conditioning programs can really help. I always tell patients to respect your abilities when you first start out playing pickleball. Kind of build into the endurance perspective, maybe not playing every day of the week for 2 hours. Try and build into it and build that endurance aspect to prevent injuries. Let's move on to the ankle. One of the most common injuries in general that we see in pickleball is the ankle sprain. It's typically an inversion mechanism where the ankle in this picture that you can see here inverts, and we injure the low ankle ligaments, or the ATFL, CFL ligaments through here. They can be varying grades of injury from 1 to 3, with obviously grade 1 being the lesser of the injury, all the way up to a pretty significant tear of those ligaments, where we say it's a grade 3 sprain. Presentation-wise, pain, swelling, and bruising, usually over the lateral aspect of the foot and ankle. Here's a good picture of typically what a sprain can evolve into over the coming days, with pretty significant bruising over the outside of the ankle. Occasionally, it can be difficult weight bearing initially, and then it improves with time, that we see with sprains. What are the red flag symptoms that could mean it's a little bit more than a sprain? Severe pain that's, again, worsening with time is something that's worrisome. Usually the sprain will get better with time. A persistent inability to bear weight, that could indicate there's a concern for a fracture. Again, persistent tenderness over the bone. Again, we're worried about fracture. Severe swelling or bruising, and any ankle or leg deformity that looks like there could be a break is a red flag, and time to see a doctor more acutely. How do we treat ankle sprains? Again, rest, ice, compression, and elevation is very important. We typically will undergo a brief period of immobilization. You'll see some patients in a what's called a cam or a walking boot, and these are typically in place no more than 10 days, just to allow the soft tissues to recover and help advance weight bearing sooner rather than later. Therapy is super important for ankle sprains. It's broken down into kind of two phases. Phase one, we're just trying to reduce the swelling, regain the range of motion, and heal the tissues. Phase two is very, very, very important because that's where we're going to get our strength back and we're going to reestablish what we call proprioception, or our ability to stabilize the ankle when we're going side to side motions. Those are typically done through strengthening exercises. Here's a great a protocol, again, that you can find online here that goes through a lot of single leg balance and dynamic stabilization to the ankle that I will tend to have patients do after an ankle sprain prior to returning to sport. One of the biggest questions we get is, when is it safe to return to pickleball or any sports after an ankle sprain? Here are kind of the criteria that we go by. Number one, we don't want to see any swelling, complete resolution of the swelling and bruising. We want to have full range of motion, full strength, and full endurance compared to the contralateral normal ankle. No pain with functional movement. So what I typically tell patients is jump forward, jump back, single leg hop. Do you have any pain with those functional movements? If not, then you're typically safe to start getting back. The last piece is a subjective confidence. So you have to feel confident in the ankle that the ankle could take the load of running or jumping. Usually the body is pretty good about telling us when it's ready to get back to play. And lastly, I'll recommend usually to have patients go back in some form of protective immobilization acutely if they get back to playing pickleball, either with a brace or taping. And this is merely because ligaments tend to heal in a 6 to 12 week window, and we're often getting back much sooner than that window. So added protection to prevent a re-injury that can really slow down and take you out of play. As a general rule of thumb, again, we kind of say grade ones can get back in 1 week, grade twos usually 2 weeks, and grade threes can take even up to a month to a month and a half before returning to play. Here are kind of predisposing factors. So limited ankle range of motion and what we call decreased proprioception, or an ability to feel where your ankle and your foot is in space when you're not staring down at it. So side to side movements when you're staring at the pickleball, but knowing where your ankle is contacting the ground is important in a protective mechanism. Patients with balance deficiency or single leg balance inabilities have issues with predisposing them to ankle sprains. And then patients that have really lax ligaments or ligaments that are loosey-goosey can have recurrence and predispose to repeat ankle sprains. What are our prevention strategies? Well, they're aimed again at the predisposing factors. So strengthening modalities, their emphasis on the lateral stabilizers to the ankle. So our muscles on the outside of the ankle, called the peroneal muscles, play a secondary role in stabilizing the ankle. Functional bracing. So patients that have history of prior ankle sprains, usually I will have them play in some form of immobilization to, again, add protection to the ankle. Proper footwear. So this is huge. A lot of people will show up to play in pickleball in their running shoes. I strongly recommend tennis shoes, and there is a difference in tennis shoes. They are thinner midsoles and they keep the foot lower to the ground. So they enhance lateral stability and reduce your chances of ankle sprains, whereas running shoes have a higher pitch and they're less stable. They're made for just inline go instead of side-to-side movements. And then, of course, the dynamic warm-ups and stretching routine to make sure everything's firing appropriately and you're nice and limber before playing. How about the Achilles tendon rupture? I'm sure you've all seen a lot of professional athletes recently that have had Achilles tendon ruptures. They're actually relatively common in pickleball injuries. There's studies that show up to about 10% of pickleball players will sustain some type of ankle injury, and Achilles tendon ruptures are up there in terms of the prevalence. The Achilles tendon is the tendon that attaches the gastrocnemius and soleus muscle, or the calf muscles, to the calcaneus or the heel bone. There is what we call a vascular watershed, or an area that doesn't get great blood supply about 4 centimeters above where the tendon attaches, and that's kind of the weak point of the tendon and the predisposed area to having the tear. The mechanism is usually a violent, what we call dorsiflexion, or toes to the nose movement when the foot is trying to be plantar flexed, or a sudden strong plantar flexion force through the ankle. Typically, patients will describe a pop sensation, and it sometimes may be an audible pop, but they'll often describe feeling like somebody hit them in the back of the calf, or something ran into the back of their calf when it happens. Most of the pain is in the heel. You'll have difficulty walking. You'll have weakness in plantar flexion, and usually there can be an easily felt palpable gap or defect over the Achilles tendon in the back of the ankle. I won't necessarily get into treatment because there's both good outcomes with non-operative and operative treatment, and I think that could be a talk on its own. So usually I say it's a surgeon-patient discussion in terms of how we manage these Achilles tendon ruptures. One of the common things I see in the office is I had pain. I felt like I tore my Achilles, but oftentimes it's a calf strain. So tried to make a chart in terms of how do we differentiate between a calf strain and an Achilles tear. Both are actually common. The mechanism is the same, but the symptoms are a little bit different. Most patients that have a calf strain will have a pull or a rip sensation in the muscle in the calf, and it's usually way up in the muscle near the back of the knee. You can actually see bruising or swelling in the calf, and there may be a period of time where you're not able to put weight, but by and large, you'll be able to kind of hobble off the court and feel like you could still walk, but with some pain in the muscle. The Achilles tear is different. You'll feel that pop sensation. Again, you'll feel like somebody hit you in the back of the calf, and most of your pain is down in your heel as opposed to in the calf muscle. Usually you'll have difficulty walking and significant weakness when you try and push off. And again, that palpable gap along the Achilles tendon is fairly easy to feel in most individuals. Again, the location of pain, calf strain much higher in the muscle belly itself. And usually with an Achilles tear, it's in the lower leg or the heel. Treatment for a calf strain, usually a short period of boot immobilization to allow the muscle to recover, rest and activity modification, anti-inflammatories, and some level of therapy program to get the muscle reactivated before you return to sport. The Achilles tear, we talked about surgical versus non-surgical, and when to see us, when to see a doc. For the calf strain, if you fail to improve with initial self-treatment, usually it's a good time to see us. But if there's any suspicion of an Achilles tear, it's generally best to see us right away to have that discussion on which route you're going to go and how we can jumpstart that process acutely. All right, what are the predisposing factors to Achilles tendon ruptures? Well, middle-aged men, 30 to 50 age group, and so what we say is the weekend warrior. So somebody that doesn't really partake in a lot of outside activities, but gets to the pickleball court once or twice a month, and that's kind of their main activities. Decreased flexibility. So the calf muscle being tight definitely increases your risk of Achilles or calf strains. And any pain in the Achilles or the heel or the calf can sometimes mean that you have chronic tendon changes that put you at risk for tearing the Achilles. Other risk factors are history of prior antibiotic use. There's a specific antibiotic that sometimes is used to treat pneumonia that comes with a little bit higher rates of tendon ruptures in general, and previous steroid injections to the area can actually predispose you for an Achilles tendon rupture. How do we prevent these? Well, by and large, a majority of these can be prevented with good stretching regimen. Again, gastroc soleus, or the calf muscle stretching, and Achilles stretching. I put a diagram over here. It's important to stretch both entities, the Achilles and the calf muscle, and you do those in different positions. So with the knee fully extended, you're stretching the gastroc muscle. With the knee bent, you're getting the soleus muscle as well as the Achilles tendon. So both of those are important to predispose or to prevent you from developing Achilles issue. Strengthening regimen, so building up the calf muscle can always prevent any injuries to that area. Again, proper footwear, so we want to use those tennis shoes when we can to prevent rolling the ankle or even predisposing to having an Achilles tear. And then dynamic warm-up and a stretching routine. So getting the muscle activated definitely helps reduce your risk of an Achilles injury. Here is another good resource in terms of recommended exercises in terms of stretching as well as strengthening that you can do prophylactically before you even start playing and to build that endurance in those muscles and prevent injury. Last but not least, one of the most common things we see is tennis elbow, or what we're going to call pickleball elbow. It goes by the medical terminology of lateral epicondylitis. It is an overuse injury, and it affects the extensor tendons to the wrist and the fingers over the elbow or on the outside of the elbow. As opposed to it actually being an inflammatory condition, it's actually a degenerative process where you get some micro tears in the tendon with overuse that can have a failed ability to heal itself, and you start to get chronic disease tendon that replaces itself with or replaces normal healthy tendon. And that's where we start to get the pain when we use that chronically irritated tendon. Again, it typically presents with lateral elbow pain. You tend to get weakness with any repetitive gripping or wrist extension exercises. So trying to hit a backhand or a forehand or grip the paddle. Treatment, how do we treat this? Well, most of it, 95% of treatment is cured with conservative measures. Rest and activity modification is big. We will tend to put patients in braces, and there's a specific brace for this called a tennis elbow brace or a counterforce brace that you could see pictured here. It reroutes vector of use of the wrist and forearm so that you kind of take pressure off the area when you're doing repetitive exercises and can lessen the pain of that area. Therapy is very big in terms of treating this and preventing it. If you're not familiar with this is what's called a TheraBand flex bar. There is, if you Google TheraBand isometrics on YouTube, you can actually see about 2 to 3 minute worth exercise regimen to strengthen the outside of your elbow to both treat the lateral epicondylitis as well as build the endurance of those muscles to prevent you from injuring or developing lateral epicondylitis. And then time. So this can be something that sticks with you for several months of treatment, but usually, like I said, 95% of people will be resolved with just conservative measures in that 3 to 6 month time period. What are our risk factors? Well, just playing pickleball or playing any racket sports puts you at risk for lateral epicondylitis. It affects up to 50% of our racket players. Poor swing mechanics, usually the backhand is involved. A heavy racket or an incorrect grip size can predispose you to this tennis elbow, and more so in the tennis than pickleball, but too much racket vibration can actually predispose you to lateral epicondylitis as well. We talked a little bit about the prevention strategies already with those TheraStick isometric exercises. Correct grip size is important, and a correct stroke technique can prevent you from developing this. Sometimes even going to a two-handed backhand instead of one-hand backhand can help prevent this as well. So in conclusion, I thought 2 slides I want to talk about to sum things up. Some of the 2 main questions I get are when to see a doctor if you have a pickleball injury, and how do we treat them? So when to see a doctor? Again, any bony deformity or severe pain, any sustained inability to bear weight, if there's direct tenderness over the bone, significant swelling or reduced range of motion of any joint, if you think you have a fracture, any joint dislocation, if you do think there's a tendon rupture like an Achilles or a rotator cuff tear or a patellar tendon or quad tendon rupture, important to see a doctor as soon as you can. And if there's pain that is worsening or not improving with some of the treatment options we talked about today, time and conservative measures. Let's see. Prevention. Okay, this is very big. How do we prevent these injuries from happening? Well, strength and conditioning programs that we talked about for every joint, posture and muscle imbalance for the upper extremity, a core to floor strengthening program for the lower extremity, and single leg balance modalities to prevent your risk of knee and ankle injuries. Flexibility is big. We talked about how to stay flexible for multiple upper extremity, lower extremity conditions, warm up and cooling down routines, avoiding overuse and prioritizing recovery and maintenance work. So it's important to spend time outside of just playing pickleball to maintain strength, give yourself a break in recovery, and then maintenance work. So keeping things active and healthy. Respect the endurance component. So respect the fact that you need to build yourself into playing, multiple hours a day, every day. Go through a process where you build that endurance as opposed to just trying to play as much as you can until you get injured. And then we talked about the correct equipment, so racket and a type of shoes. Lastly, not necessarily from an orthopedic perspective, but hydration is super important if you're going to be playing, especially during the summer and the heat. And then always making sure bone health is up to date, especially in some of our older patients that have a little bit weaker bones. It's important to make sure you're supplementing with vitamin D or calcium if you have weaker bones. So I think we'll go to the question section here and see if we can answer some questions. So first question, how does orthopedic research impact your practice with sports medicine? It's a good question. It impacts everything. I mean, here at Ortho Carolina, we have a robust research section. So a lot of what we do and what we recommend for patients is backed by the research that we do. So we're constantly always coming up with new research questions. Pickleball being a newer sport that's grown, we're always constantly looking at, okay, let's look into our injury patterns. What are we seeing at the most common? How do we treat those? And then we can research those topics and publish on them to kind of help us guide treatment. Are there any conditions or ages for which you'd recommend avoiding the game? No, I mean, this is what's the beauty about the game. This is a game that's built for all shapes and sizes, all age groups, from young to old. So I highly recommend. It's a great sport. It's a fun sport, and I think there's a role for everyone. What exercises should I do to avoid knee injury? So like we talked about, very, very important, lower extremity, core to floor. So making sure your core is strong, making sure your hips are strong, and make sure you have appropriate single leg balance can really help you avoid those knee injuries. Aside from stretching, is there anything that can be done to improve joint lubrication like supplements? Yeah, that's a great question. So chondroitin is a supplement that some patients will take. It's an over-the-counter supplement that can help with the natural lubrication of the joint. There's mixed studies on whether that helps prevent issues or not. I think there's little side effects or downsides to doing it. So when I counsel patients about it, I think if you're thinking about it, there's definitely little harm to it. So I recommend it in patients that want to maintain joint health. I think by and large, though, it's much more important to maintain flexibility, maintain appropriate weight, which reduces joint contact forces and probably does more than a supplement will. Can you play pickleball after joint replacement? Yeah, so great question. We're just starting to actually research this and look into this. So this is kind of a hot topic in our field, especially for both lower extremity and upper extremity. The biggest ones being hip replacement, knee replacement, and shoulder replacement. My discussion in practice with patients regarding this is pickleball is a little bit less impact, lower energy than tennis. So I think it's appropriate to get back and play pickleballs, especially at least in the double session or the doubles format after a hip, knee, or shoulder replacement surgery. I typically tell patients that we should wait probably 4 to 6 months after those joint replacements before we get back in. And I usually like to make sure that people are recovered and they're appropriately strengthened, and they really have the ability to decrease the risk of injury. But yes, I think it's appropriate to get back and play after a joint replacement surgery. Are there any stretches I can do to avoid shoulder injuries? Yeah, it's a great question. So our three kind of stretches or direction of stretches are what we call forward elevation. So above head, external rotation out to the side, and internal rotation behind the back. The AAOS shoulder exercises that I alluded to in the presentation, in the beginning section of that document, there are guided stretches that you can perform, and we'll walk you through on how to do those exercises and stretches. So something that I highly recommend prior to play. Can you share some general safety guidelines for beginner pickleball players? Yeah, so general safety guidelines. I think it's always a good idea that if you're going to start playing, number one, play with experienced players who can kind of teach you the ropes and will teach you the right way to play, if that makes sense. Number two, make sure that when you start playing, it's a progression. So go out there and learn how to hit the ball first before you get into competitive matches. Build up to certain competitive matches where you're not playing all day, every day. And then as you start to develop more and more confidence in the game, then you can advance to more competitive environments. I think some people will make a mistake of just trying to get out on the pickleball court and play singles competitive right away. I think that's where people may run into some problems with increased risk of injury. What's the difference between a sprain and a strain, and how do I know which one I might have? So good question. Again, this is something that we talked about, at least from a knee perspective. A sprain usually involves a ligament or a structure that connects a bone to a bone, and a strain usually involves a muscle or tendon or lining of the knee. It's a little bit of nuance, and we often treat them the same. So for lack of a better term, both kind of mean very similar things in terms of how we treat them. Again, the sprain or the strains are usually after acute injuries, not a ton of swelling, but from a knee perspective, can still put weight on it, gently get range of motion, and usually they get better over a short period of time of a couple days. What's the best type of shoe to wear for pickleball to reduce injury risk? Yeah. Tennis shoes. We should start calling them pickleball shoes, but tennis shoes, again, they're lower. Your foot is lower to the ground. There's more lateral support, and the pitch of the shoe coming down from the heel to the toe is less, so that you're more stable on the ground. Definitely reduces your risk of injuries, especially around the ankle. Can playing pickleball make arthritis worse? It's a good question. So I'm going to say yes and no. Yes, in the sense that if you don't respect the endurance component to pickleball, or usually in the arthritic environment, or when we're talking about arthritis, doing too much too quick can definitely increase arthritic symptoms if the body's not used to it. But building the endurance where you're not playing pickleball too many days in a row and you're giving yourself breaks, then I don't think that you put yourself at risk for arthritic flare-ups if you're smart about it. So I think that answer is a yes and no, if that makes sense. If I feel pain while playing, when should I stop and see a doctor versus just rest and ice it? Great question. So remember during the presentation all the red flags that we went over. Usually in general, if there's any deformity, inability to bear weight, or lack of joint range of motion, those are usually red flags, and that's time to see a doctor to rule out something like a tear or a fracture or a break in the bone. If any of those are absent and your pain and symptoms start getting better acutely in a day or two, that's usually a good sign that the injury will resolve on itself with time and some of the measures we talked about. If your pain is not improving over a period of several days, or it's getting worse day to day, that is abnormal, and again, time to see a doctor. Are cortisone shots safe if I develop a chronic overuse injury from pickleball? Again, all right, yes and no. So it depends on what we're using the cortisone shot for. In general, we want to try and limit cortisone shots around tendons because that kind of predisposes or gives you a little bit risk of a tendon tear from the cortisone shot. But usually in a joint like a knee or a shoulder, it's safe because we're not putting it around a tendon. So in an arthritic perspective, a cortisone shot is great inside a knee to reduce the swelling and inflammation. But if we're talking about a tendon issue, we tend to try and avoid the cortisone injections around tendons. What is the most common injury from pickleball you see in practice? So probably the most common is an ankle sprain, believe it or not. That is probably the single most common pickleball injury acutely. The chronic or overuse injuries are probably a tie between rotator cuff tendonitis or bursitis and lateral epicondylitis or tennis elbow. Is a compressive knee sleeve suggested as a preventive measure for an arthritic knee that swells? Yes, compressive knee sleeves can be great. I recommend those when you play, especially if you feel like you're constantly swelling, and especially in the arthritic knee. It can provide some gentle support and can prevent the swelling if you're wearing it during play. The one thing I don't like is if there's any rigid support of that knee brace on each side. So the most support I like when you're playing is just a compressive knee sleeve. Nothing with metal bars on the side or straps that go around the knee. I think those can actually increase your odds of injury. But in general, yes, compressive knee sleeve can be good to play with. Are there thoughts on rice evolving, specifically the amount of ice, and to a lesser extent rest? So yeah, in general, I think some of the technology that we have is kind of evolving the rest ice compression and elevation. Is it making things better or advancing how quickly? That's a great question. Some of the icing units that we have where you can constantly run ice safely, and there's machines where you can get a compressive effect with the ice that are a little bit more expensive. Do they work better than just a bag of peas that you grab from the freezer? I don't know. But in general, if you're going to use ice directly on the skin, my recommendation is 20 minutes on, 20 minutes off, usually for a cycle of an hour or two. Some of the more technologically advanced icing units that you can use, especially you'll see some of our patients after surgery using those. You can use those constantly around the clock because they have that system where it ice on, ice off built into the machine settings. Tennis elbow type injuries. Is there any preventative type brace or band that you feel is best or better? How long should you use such brace? So I don't actually think that there's any good measures or any good braces out there or braces that I would recommend to prevent tennis elbow. I think your best bet is to strengthen those muscles and with those exercises we talked about, the theristic isometrics, to get that muscle healthy and prevent the risk of developing lateral epicondylitis. But I don't recommend usually any prophylactic bracing or bands that you use to prevent tennis elbow. Are tennis elbow and pickleball elbow the same thing, and do you need surgery for it? Yes, so we're going to start calling it pickleball elbow, but traditionally it is called tennis elbow. It's the same thing. The medical terminology is lateral epicondylitis. And do you need surgery for it? Not necessarily. I tell my patients 95% of patients will improve and have the ability to avoid surgery. So the odds are pretty good for not needing surgery. Usually the time that we consider surgery is after the failed conservative measures, which are usually upwards of near six months to a year of non-operative management before you go the surgery route. Well, that concludes everything. Thank you guys for attending tonight's live webinar. Just a reminder that there will be a replay of this available on our social media platforms. Thank you guys for attending, and I hope you all have a great night.